مرحبا دكتورة. So now we are in live. So first of all, good afternoon or good morning for everybody who will attend and follow us in this series of webinars organized by Mr. Abdurrahman Al-Brahimi and Dr. Lunis. In behalf of the community of pathologists of North Africa, I should thank Dr. Professor Raja Rabah to join us and to give us some of her very precious time to give us a lecture about pediatric round blue cell tumors. First of all, and before her lecture, I should introduce Professor Rabah to the audience. Maybe some of our colleagues didn't know about her. So Professor Rabah received her MD from Damascus University School of Medicine in Damascus, Syria in 1980 with honors. She completed residency training in anatomic pathology at both Memorial Medical Center, New York University Medical Center, Flushing, New York, from 1982 to 1985, followed by Pediatric Pathology Fellowship at the Children's Hospital of Pittsburgh, University of Pittsburgh from 1985-1987. Dr. Baha is board certified in both anatomic pathology and pediatric pathology. She served as director of the Department of Pathology at Al-Maqasid Hospital in East Jerusalem from 1987-1994. In 1994, she joined the faculty of Wayne State University School of Medicine as assistant professor. She was promoted to rank of associate professor in 2002 and to professor in 2009. She worked as an associate pathologist at Children's Hospital of Michigan in Detroit, 1994 to 2009, and she was appointed as Director of Pediatric Pathology Rotation at Wayne State in 1999 and Program Director of Pediatric Pathology Fellowship in 2007. Dr. Rabah joined the Faculty of University of Michigan Health System in July 2009 as Professor and Director of Pediatric Pathology. Since 2010, she has established the Pediatric Pathology Fellowship Program at the University of Michigan and is the Program Director. In 2011, she became the Director of Pediatric and Prenatal Pathology at the University of Michigan. She is the author of more than 100 peer-reviewed publications and abstracts, and she was invited on numerous occasions to deliver extramural, regional, national, and international presentations. She served on numerous department, health system, and university committees, such as the Institutional Review Board and the Advisory Committee of Clinical Track Appointment and Promotion. In 2013 to 2014, she served as a member of the AGME Milestones Pediatric Pathology Fellowship Working Group. She served as a member of the Board of Trustee and Representative Ambassador of the Michigan Society of Pathologists 2012-2017. She is a member of the American Society of Clinical Pathology Race Committee in the Pediatric Pathology Fellow Exam Section, and she served on several committees of the Society of Pediatric Pathology, and currently she is the chair of Fellowship Committee. As you see, her CV is very thick, and that she is working. She was working very hard for a long and in this very specialized field of perinatal and pediatric pathology. Now, the line is for Professor Rabah. Professor Rabah, please, can you start?
Okay. صباح الخير. سوري أنا مش قادرة أشوفكم، يعني مساء الخير عندكم، وبتمنى أنه لو كنا شايفين بعض وجه لوجه إن شاء الله بالمستقبل. So ما في وقت كتير، بس رح أبدأ هلا أحكي عن ال pediatric round blue cell tumors, something very common in our practice when we're dealing with pediatric patients. Can you hear me well, and can you see my slides?
You can put, please. You can put your comment on the chat box.
Okay.
Yes. Okay. Yes. Okay. Okay, Doctora.
Okay, just go ahead. All right. Yeah. So round blue cell tumors are a problematic area in pathology for all pathologists because they're really very similar tumors under the microscopes for the pathologists, and the diagnosis is usually not easily recognized. This name, sorry, is given to group of tumors that they're highly malignant. They are destructive tumors. They tend to be fatal if not treated appropriately. They are considered as congenital tumors, and they cause, tumors and widespread metastasis in specific patterns based on the organ of origin. And the name is usually given based on the organ that where they arise. Often they have characteristic genetic abnormalities that now we are using to make a diagnosis or to specifically allow some prognostic features for the clinical use. So the most common round blue cell tumors we're talking about today are the neuroblastoma, rhabdomyosarcoma, and Ewing sarcoma. I'm not going to touch a lot about lymphomas because they kind of are similar to the adult lymphomas, and it will be very difficult to cover all these tumors in details in this 1 hour lecture. So there are other round blue cell tumors that may enter the differential diagnosis for somebody who's dealing with a piece of tissue from a child. And that's the list that most commonly is seen. I'm not going to read it to you, but basically any tumor can sometimes have a small cell component and mimics the classic round blue cell tumors that we often see in our practice. So how do we make a definitive diagnosis? Because that's our role as pathologists. We really need to know the adequate clinical data. So the more clinical information that the pathologist is provided with and think about, the easier or maybe less difficult the diagnosis becomes. We really need good size biopsy to be able to establish the diagnosis. Because if you have a small sample like the one I have in the middle here, there is not a lot of tissue that allows you to navigate and look around and figure out what's the tumor, nor enough to make stains to actually provide appropriate interpretation. So the size of the biopsy in our practice, and I don't know how is it going with you, we don't see these tumors anymore as excisions, honestly. Most of the time, they excise them after treatment and they lost the histological classic features. Sometimes we may get open biopsy like this example here, but the majority of our samples nowadays are falling in this kind of interventional needle biopsies. There is benefit of that, which is that those procedures are less invasive. They are better for the patient because they don't have complications. However, they complicate the pathologist's life because the sample is small and it is extremely important for the pathologist to appropriately triage, send for definitive diagnostic tests that are needed and require expertise in interpreting tumors based on small biopsy. So this diagram I made for teaching residents, and what I'm trying to say here, that you really can do a lot with a small piece of tissue. So most of the time what we get is a fresh tumor. So there is a protocol that our surgeons or interventional radiologists, they are required to send the tissue to the lab fresh. And that means a pathologist or a designee is going to be in the lab waiting to appropriately triage that piece of tissue, be it needle biopsy or an open biopsy. And the tissue often, is subjected to a frozen section. And I'll explain to you why we like to do frozen section. It's not because we are going to make a diagnosis. It's the opposite. It's actually to appropriately triage the piece of tissue that we are looking at. And we may do touch prep. we do definitely cytogenetic and flow studies for pediatric tumors, but the bulk of tissue actually required is to be fixed in formalin and processed for histology and immunohistochemistry. We freeze tissue in -70 for molecular studies if needed, and we also save tissue for biobanking because that's the way to learn in the future about changes in science, doing sophisticated studies, including sequencing, next generation sequencing, and so on. Electron microscopy, you may put a little piece for EM, but actually it has fallen from preference and we don't do it anymore routinely for diagnostic purposes, but some labs may prefer still to save a little piece of tissue for electron microscopy for the future. So what is the role of the frozen section in pediatric small round blue cell tumor? It's truly just to say, are we dealing with the tumor tissue? We wanted to guarantee that the procedure is successful. We wanted to know the needle biopsy or the needle was actually in the tumor versus normal tissue or necrotic tissue that's not going to help us to make a diagnosis. So we want to know if this is really tumor tissue. We want to judge if that we have enough tissue viable to be able to make the diagnosis next day and to appropriately plan where we're going to send the tissue. Should we prioritize molecular studies? Should we prioritize cytogenetic? Should we send for flow if we suspect lymphoma, and so on? But the precise diagnosis is usually deferred in our practice unless it's really very obvious. It's usually deferred to permanent sections and the surgeons are comfortable with that. The diagnosis is often round blue cell tumor present and we have enough tissue and you know we will give you the diagnosis next day. The definitive diagnosis really require a combination of the clinical information and the routine histology. That's the most important, but don't forget that we need sometimes or often to do immunostaining and other stains in our practice. And nowadays, molecular markers are becoming extremely important to subtype pediatric tumors. But I want you to remember, even though if you know the clinical history, always put in mind when you're dealing with these tumors, they don't read the book and they can follow a pattern that's totally unexpected. So be open-minded and don't get confused with the immunostains because sometimes there is a lot of overlapping and things don't really make sense. So there are different immunostains that are used in practice. The most common will be in the pediatric population, the lymphoid markers, the muscle markers, the neuronal markers, and the CD99. Those are the most important. Sometimes you may have to throw some epithelial markers if your tumor differentiation is confusing, or S100 protein if you're thinking about nerve-sheath tumor or melanomas, but often the minimum panel that we use is this panel. And always do not do one stain in your workup. One stain is really confusing and delays things. I usually do the minimum panel, which is CD99, muscle markers, and I do two, myogenin and desmin together. It's not because I want to confirm the muscular differentiation. I use both markers to subtype rhabdomyosarcoma. So from the beginning, do it together. It becomes easier to type and make the diagnosis. A leukocyte marker, CD45 usually, generic one, and neuronal marker based on your preference, neuron-specific enolase, PGP 9.5, chromogranin, they all work depending on your lab and what you like. So the minimum requirements is a panel approach for immunostain, and those are the the smallest panel that's usually used. Molecular markers in round blue cell tumor diagnosis. We know that a lot of these pediatric tumors tend to have simple cytogenetic abnormalities. They're usually in the form of balanced translocations. That's different than the adult tumors. Pediatric tumors, they're simple genetically. They usually have one translocation. They may have other fusions or abnormalities, but the classic finding is usually a simple translocation that promotes the tumorigenesis in this population. And now we're using those markers to establish a diagnosis by having some immunostains like CD99 or BCOR stain to help us establish or confirm a diagnosis. And in some of them, the markers, the molecular markers, are helpful in prognosis, such as the NMEK in the workup of neuroblastoma. So those are the most common molecular markers in the most common pediatric tumors. And I'm going to go in details in a little bit in each specific tumor when I describe it. The question that is practical, especially in places where molecular labs are not readily available, can the pathologist make a diagnosis without having the molecular advantage or the techniques available to them? And the answer, really, in practical purposes, in the majority of cases, histology and immunostains are enough, put together with the clinical information, metastatic pattern, etc., especially in, classic, typical cases. However, molecular studies are sometimes needed, and they are needed when you have a tumor that morphologically is not classic. Something like if you have a tumor that looks like Ewing, but you're suspecting synovial sarcoma. It's a poorly differentiated sarcoma that mimics Ewing. And yes, you need to definitively make a diagnosis because the protocol to treat Ewing is not the same like synovial sarcoma. So we're obliged to do the molecular testing if that is our differential. In cases when you have a round blue cell tumor in an unusual age group, if your patient over 50 and you have neuroblastoma or a Ewing sarcoma, you better confirm it molecularly because there are small cell carcinomas and other tumors, especially if you have a lousy sample, that can mimic those round blue cell tumors. If you have typical morphology, but like unusual pattern, let's say you have peanut in the kidney, that is a tumor nowadays in our hand, requires confirmation because you could have truly a peanut Ewing tumor arising in the kidney, but you need to differentiate it from other renal tumors such as clear cell sarcoma, blastema predominant Wilms tumor, when you really don't have immunostains to help you appropriately. Especially important to rely on molecular testing when you have limited samples. And the majority of our current practice is based on limited sampling, which is needle biopsies. And sometimes the immunostains don't work on needle biopsies if they're crushed or they're necrotic. So the immunostain pattern becomes confusing. If the pathologist is in that situation, it's better to rely on molecular testing. First, I'm going to talk about neuroblastoma, which is the most common pediatric tumor in routine practice if you have pediatric population in your patients. What you need to remember is a neuroblastoma is really a spectrum of peripheral neuroblastic tumors. It starts as poorly differentiated tumor. Most commonly, as you know, it's seen in the adrenal gland, retroperitoneum, but it can be seen in other sites. It may present as metastasis, so always think about it. The survival is different based on the degree of maturation. What you need to remember that neuroblastomas, the poorly differentiated tumor, is really associated by very poor survival, as low as 4%. However, these tumors undergo several degrees of maturation and differentiation, leading to benign tumors, basically, that we call ganglioneuromas. I'm going to talk about important thing for the pathologist, which is how do we deal with these samples and what is important from us to report to the clinicians. So how much tissue is required in the workup of neuroblastoma nowadays? The bottom line changed. So like 5-10 years ago, we were required to have excisions. Then we became like open biopsy. And nowadays, the international neuroblastoma protocols accept needle biopsies. However, the condition is that you need to have enough number of cells that are viable and readable to count the mitosis karyorrhexis. And the minimum number of cells required is 5,000. And yes, needle biopsies can give you that. I'm going to show you how. Open biopsies becoming less and less, as I said, in the West. I don't know about your practice, but in our practice, we are basing the diagnosis on needle biopsies. Bone marrow is acceptable for grading of neuroblastoma, but we cannot do mitosis karyorrhexis index because you do not have enough cells usually in the sample. Metastatic sites are acceptable even on needle biopsy to read. This was a condition that you cannot read metastatic sites. That changed in the last 5 years. But you have to mention in your diagnosis as a pathologist, the qualifier, that this is a limited sample and the diagnosis, is limited, basically. This is the old international neuroblastoma pathology classification, also known as Shimada classification, which breaks the neuroblastic tumors into favorable or unfavorable histology. And if you're not familiar with it, this is the ABC in classifying neuroblastoma. This classification requires us to first look at the Schwannian development in the tumor. I'll show you some examples. If you have more than 50% of the surface of the tumor Schwannian collagenous stroma, then you are going to ganglioneuroblastic tumors. That can be either the most common ganglioneuroma, which is benign tumor, or ganglioneuroblastoma that's intermixed, which is also favorable histology tumor. They're a little bit more aggressive than ganglioneuroma. Or the nodular type ganglioneuroblastoma, which I'm going to show you example, and that can be either favorable or unfavorable based on the degree of neuroblastic differentiation and age of the patient. The most common tumors in practice are usually classic neuroblastoma. And in this case, there is more than 50% of the surface of the tumor or the biopsy that's actually Schwannian stroma poor, and I'll show you what does that mean. Then after you decide the Schwannian background, you're going to read the neuroblastic differentiation, and I'll show you how. Then you go to the mitosis karyorrhexis, and you link those findings into patient age. The magic cutoff age is 18 months, 1.5 years. Usually tumors below 1.5 years, the majority fall into favorable histology unless they are undifferentiated or poorly differentiated with high mitosis and karyorrhexis. And the majority of tumors over 1.5 years, they tend to be unfavorable histology. Because what we expect that neuroblastoma, if it's a congenital tumor, that by 18 months of age, that it decided to be mature. If it didn't, or it's still mitotically active, then it is not very favorable because it's didn't follow the maturational sequence that's expected. Yes, we can do the classification again as a reminder on primary tumor biopsy or large sites of metastasis. But the tumor has to be without treatment. Treated tumors cannot be classified based on the Shimada classification because chemotherapy will induce maturation and it will change the morphologic appearance of the tumor. So once you made a Shimada classification on a primary tumor, it's going to stay for the rest of this tumor. Even if it recurs in the future, you do not change the classification. It is what it is. It's the primary tumor, not the metastasis, not the recurrence, that's going to decide after treatment. You require sufficient size, and now this is 5,000 nuclei. As I said, bone marrow is good for neuroblastic differentiation, does not help with the mitosis karyorrhexis. Remember, this classification is age-linked. So two tumors can look the same, but below 18 months of age, it's is favorable. After 18 months of age is unfavorable. And that's something not good for pathologists because, like, it's not the patient age, it's what I see under the microscope. But with neuroblastoma, it's a different story. So this is how we do it. We start with the Schwannian stroma, and as I said, the majority of tumors fall as neuroblastoma stroma poor. What do we mean by stroma poor and stroma rich? Stroma poor is usually a neurofibrillary, very acellular or poorly cellular stroma. It's basically the neurites of the neurons, which are the neuroblasts. While Schwannian stroma rich is this collagenous, fibrous, more cellular stroma. So the neurofibrillary stroma is what you usually see within the rosettes. And this is an example of an intermixed ganglioneuroblastoma, which has both. It has the Schwannian stroma rich in the right side, collagenous stroma, and the stroma poor is this thin fibrillary material that's holding the neuroblasts. So that's the basic definition that needs to be followed to decide Schwannian stroma poor versus Schwannian stroma rich. Schwannian stroma rich is like ganglioneuroma. That's what it is. Schwannian stroma poor is the classic neuroblastoma. So when we look next step, which is after we decided if this is Schwannian stroma poor or rich, we look at the neuroblastic differentiation, and we're allowed three categories. Either your tumor completely undifferentiated, poorly differentiated, or differentiating. And the reason we do that, what does it mean? What it means, in undifferentiated subtype, we cannot recognize that this is neuroblastoma based on H&E alone, meaning you have no obvious differentiation, no ganglion cells, no recognizable neurofibrillary background, no rosettes. You cannot find rosettes. Neurofibrillary stroma, you cannot see it on H&E. All what you see is usually sheets of round blue cells with a background that has no differentiation. Those tumors are usually associated with high mitosis karyorrhexis. They tend to have prominent nucleoli and often biologically are aggressive because they have NMIG amplification. In routine practice, usually immunostains is required to uncover the differentiation. So what you're going to have to do, because those tumors do look like Ewing. So neuroblastoma Ewing, that's your differential on H&E. But what you do is a neuronal marker, and then usually it is diffusely positive and CD99 negative. So the must combination is NSE or PGP 9.5, diffusely positive, CD99 negative, you make the diagnosis of neuroblastoma. Now, there is a more recent antibody, which is the PHOX2B antibody, that appears to be more specific. So you are required to do that in practice if you're not comfortable with the diagnosis. It is not available in all labs. I don't have it in my lab. I base the diagnosis on those two markers and on molecular studies to establish the diagnosis in this subset of undifferentiated neuroblastoma. And they're extremely rare. They're not common tumors. Then what do we mean by poorly differentiated subtype? That is the most common type of neuroblastoma that we see in our practice. The tumors are obvious on H&E. They do not need immunostains. They do not need molecular for diagnosis. They need molecular for biology studies to establish their prognostic stratification, but not for diagnosis. They're usually nests. The tumor have nests of round blue cells. In the background, you do recognize the neurofibrillary background stroma, which is the stroma pure. You may find rosettes to a variable degrees. You may see some ganglionic cells, but they need to be less than 5%. So if you have all these criteria, then you call it poorly differentiated neuroblastoma. And as I said, this is the most common type of neuroblastoma in daily practice in children. The differentiating subtype, those are less common. They often are seen in older patients. And yes, there are nests of neuroblastoma, neuroblasts, and there is ganglionic differentiation. And by that, I mean synchronous maturation of the nuclei and the cytoplasm. So it has to be a decent appearing ganglion cells. They can be variable. They can be from 5% to 75% of the tumor that's ganglionic. Doesn't matter. It's still, as long as there is a neurofibrillary background, it's a neuroblastoma. So if you, sometimes what I notice in practice that a tumor has a lot of ganglion cells is called ganglioneuroma, but the definition of ganglioneuroma versus neuroblastoma is not based on the presence of ganglion cells. It actually is based on the presence of the neurofibrillary background. So if you still have neurofibrillary background, it doesn't matter. Even if all your neuroblasts became ganglion cells, it is still a neuroblastoma. Need to be treated as such. It can be unfavorable histology and needs chemotherapy. While if you call it ganglioneuroma, those tumors do not get treated. They're benign. They get excised. So how do we do mitosis karyopexis? So with experience, mitosis karyopexis is usually easily done by just semi-quantitative methods. But when you're starting earlier to do mitosis karyopexis, it really needs appropriate counting. We do lump mitosis and karyopexis when we're dealing with neuroblastoma, because those tumors, it's very difficult to differentiate between mitotic cell or fragmented nuclei. That's why they got lumped together and we count them together. You need to do the count on your 40x, which is the higher magnification, with your objective 10, so it's 400 magnification. And with, different microscopes may give you different number of cells and the degree of cellularity of the tumor, but generally, most microscopes in most poorly differentiated tumors, I'll have to say, you get about 1,000 nuclei on one high power field. So basically, you don't need to count a lot of fields. You only need to count about 5, but you need to count them from different areas to come up with a total count of mitosis and karyopexis. And the count needs to be averaged. So it's not, don't just go to the highest mitosis karyopexis areas. You need to choose several areas to actually be able to do the count appropriately. In the semi-quantitative type, which is easy when you have experience with it, So in the low tumors, usually it's less than 2% of the nuclei have either mitosis or karyorrhexis, and the total count is 100 out of 5,000 nuclei. Now, in the high mitosis karyorrhexis, it's usually more than 4% or 200 nuclei. And those are usually obvious. They are tumors with like the mitosis and karyorrhexis kind of jumping at you easily. So those are some mitotic figures here, but there are a lot of karyorrhectic nuclei. And as I said, sometimes it's difficult to differentiate mitosis from karyorrhexis. So if your tumor in low power looks like this, it's low. If it looks like this, it's easy, it's high. And then you struggle usually with the ones in between that you need to do more appropriate counting. So after you do the mitosis karyorrhexis, you need to link it with the age, and then you assign favorable or unfavorable histology, which is the important step for the oncologist to treat. Intermixed ganglioneuroblastoma is a tumor that has composite component, including neuroblastoma, which has neurofibrillary stroma in the background. They're usually nests, they're small, they're scattered throughout the tumor, and the background has more than 50% of the surface area with collagenous Schwannian stroma. That's the mature stroma. Those tumors are a little bit more aggressive than ganglioneuromas, but they are not, usually they do not need chemotherapy. They're favorable histology. The nodular ganglioneuroblastoma, those are rare tumors, but usually there is a grossly recognizable hemorrhagic nodule. The size can be variable from very small microscopic to recognizable large nodule, and sometimes it's actually may overcome the tumor. And the prognosis is usually based on the differentiation of the neuroblastic nodule linked with the age, and it can be favorable or unfavorable. If they are unfavorable, those are the worst kind of neuroblastomas. They're very aggressive. Ganglioneuroma, you're familiar with it. It's usually the neuroblastic nests are gone. All what you have are ganglion cells, and Schwannian stroma can be maturing ganglion cells or mature. Both are the same. They're surgically removed and have no metastatic potential at that stage. Important to pay attention to the biologic features of neuroblastoma. The clinicians do require routinely knowing that information to assign risk for the patient and to assign the patient to appropriate treatment protocol. So the common biological studies that are performed on neuroblastoma include, as a must, amplification of the MEK oncogene. So the amplified tumors are associated with poor prognosis or poor outcome. We do send for loss of heterozygosity of the 1Q, 1P, or gain of 17Q. That's usually done by sequencing, and that is also the presence of loss of heterozygosity is associated with decreased survival and increased risk of recurrence. Diploidy is associated with favorable outcome, while diploidy is associated with less favorable outcome, while hyperdiploid tumors are associated with more favorable outcome. So the MEK amplification is strongly related with poor outcome and advanced disease and resistant to treatment. It is present in about 20% of all tumors that come to practice. And usually those tumors tend to be either undifferentiated, they're very pleomorphic looking tumors under the microscope. So those are maybe histological clues for routine practice for us to suggest that this tumor is going to be amplified. There is a correlation. If your tumor is undifferentiated or poorly differentiated with high MKI and pleomorphic cells or prominent nucleoli, we call it the bull eye appearance, that seem to be quite common in patients who have in-MYC amplification. So after neuroblastoma, the second common tumor that we see in practice is primitive peanut or Ewing sarcomas, bone and soft tissue common tumor. So the definitive diagnosis nowadays, now that's more common. Okay, now it became bigger. Is it me? The definitive diagnosis is actually based on the combination of immunohistochemistry and molecular finding. Tumor can occur in soft tissue and bone. So this is an example of an iliac bone tumor. It's a primary bone tumor, and that's a primary soft tissue intercostal tumor. Both tumors histologically are similar, they overlap. We used to differentiate those two entities in the past. Nowadays, they are considered the same tumors based on the molecular characteristics. So the tumor is usually undifferentiated. There are cellular sheets of monomorphic round to ovoid cells, usually very scant amount of cytoplasm, chromatin clump. There is a dark light type of appearance in the nuclei. There are variable histological appearances or patterns. The classic Ewing in the bone has the dark light nuclear appearance. It can happen also in the peanut, in the soft tissue. But, you know, we learned that Ewing can have multiple atypical appearances, including large cell variant with conspicuous nucleoli. It may have a dementinoma-like appearance sometimes, with the sometimes even alveolar appearance, pseudo-alveolar appearance, or sometimes the stroma can have sclerotic background, sclerotic variant of Ewing. However, all these histological variants really have no impact on prognosis or treatment. So we don't usually type them specifically, we note them. We need to learn the histological variants to help in the diagnosis, but it's not required that we subtype them because there is no impact on outcome. I've seen Ewings with a starry sky appearance mimicking Burkitt lymphoma. I've seen some with a lot of rosettes mimicking neuroblastoma. I've seen tumors with necrosis. Sometimes the necrosis overweight, you know, much more than the viable tumor cells. So pay attention to all these features without needing to actually type them in the report. Just know that they do exist. So how do we make a diagnosis? The current standard require, if you have classic histology, classic location, that you do CD99. It's a must to do CD99. And the diagnosis is based on the presence of strong, and I'm going to emphasize again, membranous CD99. So cytoplasmic nuclear staining alone does not qualify. What we need is membranous CD99. The problem that CD99 is a sensitive stain, and it can be messed up with decalcification, crushing, poor fixation. All these things can make it more difficult to interpret. But that's how we make a diagnosis. This stain is really sensitive, so it is good for diagnosis if you see membranous staining. However, it's not specific, because we can see CD99 staining in other tumors, and I'm going to mention that, including in lymphoma. You could see CD99. It could be membranous completely. So you need to see all these things together, not just look at the stain. And that's why we do the panel, because it's not enough to look at CD99. And if you have membranous staining, you call it the day. This is Ewing. It could be something else. There are other stains, including the anti-Fly1 antibody and the NKX2 that are probably, Fly1 is less sensitive. It's really a difficult antibody in multiple labs. It doesn't work well. The good thing about it, it's nuclear. And if it's diffuse and positive, it's helpful. But sometimes it just doesn't work in all the labs. And with different batches, it gives the lab difficult time to stain. We stopped doing it. I'm just using CD99 nowadays. NKX2, it looks more promising. It's not available in all labs, and I don't have it in my lab, but if it's available, it's helpful. It's more specific. So classically, Ewing will stain, as I said, with a membranous type of CD99, but there are other markers that can be positive in this tumor, including neuron-specific enolase or other neuronal markers. And usually it has a funny looking stain. It has a mosaic appearance or patchy areas of staining. So this combination is very helpful to differentiate Ewing from neuroblastoma undifferentiated, because those tumors are very common in the practice. So if your tumor is CD99 positive, NSE patchy, it's Ewing. But if your tumor is NSE diffuse, CD99 negative, is neuroblastoma. Cytokeratin also gives patchy staining, and it has characteristic like dot-like appearance in the cytoplasm. If you have that pattern, it may help you to make a diagnosis of Ewing. Genetically, Ewing sarcoma is associated with characteristic EWS related translocation. The most common is associated with translocation 1122, with the EWS partner is FLY1 in majority of cases. But there are other partners that are discovered, and we probably still are going to learn more of these partners of the EWS. You see it in both Ewing and in peanut, and you detect it either by FISH, RT-PCR, or by conventional cytogenetic. The minimum requirement or standard of care nowadays to make a diagnosis of Ewing peanut is actually to have classic morphology, immunohistochemistry, and that's enough. Just histology, immunochemistry in the right age. However, if you have some unusual pattern, like in this case, I have this comido type of pattern that it looked very bizarre, I had to do molecular testing. I needed genetic confirmation, and this tumor turned out to be Ewing. It was a primary bone. It was in the jaw, but it has focal areas with this comido type of pattern that's very unusual. Although the CD99 was diffusely membranous and positive, it wasn't enough to establish or confirm the diagnosis. You do require genetic in those type of situations. Differential diagnosis most common, as I said, undifferentiated neuroblastoma, poorly differentiated synovial sarcoma can mimic Ewing, alveolar rhabdo sometimes, and the round cell sarcomas that are associated with CIS or B-core type of arrangement, and desmoplastic small round cell tumor. Most of them you can solve it in immunostain, but molecular testing is required sometimes. Rhabdomyosarcoma, very common, a soft tissue tumor in the pediatric age group. The current standard for us in dividing those tumors into embryonal or alveolar rhabdomyosarcoma. And we're familiar with that. You know, classically, embryonal rhabdomyosarcoma, it tend to have some skeletal differentiation. There's variable cellularity. Sometimes the cells are large, and they have significant amount of cytoplasm and strap cells to make a diagnosis. By immuno, usually you have desmin and myogenin immunostains, but the requirement to classify it as embryonal rhabdo is that the myogenin nuclear staining does not involve the majority of nuclei. So the cutoff is 70%, usually less than 70% in embryonal rhabdomyosarcoma. And that's the reason why we use 2 muscle markers to confirm diagnosis of rhabdomyosarcoma and then to subtype it. Spindle cell variant, usually common as a paratesticular tumor, head and neck, predominantly spindle cells, tend to have fascicles, whirling appearance. It may mimic leiomyosarcoma. And desmin and myogenin both are positive. Myogenin less than 70%, usually actually way less than that in spindle cell variant. The sclerosing rhabdomyosarcoma is more recently recognized and lumped under the spindle cell type rhabdomyosarcoma. We're learning in the pediatric age group that this tumor is actually a heterogeneous genetic group of the spindle cell rhabdomyosarcoma, and it's variable different between adult and the pediatric age group. The current standard up to the 2013 WHO classification, it's still lumped under spindle cell rhabdomyosarcoma. It has overlapping histology and clinical features, and they both, the spindle and the sclerosing type, tend to have the MyoD1 point mutation. The important thing to remember in the spindle cell rhabdomyosarcoma that it can be deceiving and look like other spindle cell tumors, not round blue cell tumor. Sometimes it may have rounded cell appearance, and that's why I'm talking about it more here. So this is an example of a head and neck type spindle cell rhabdomyosarcoma that the rounded cells had this very hyalinized type of matrix. Some of the cells did have cytoplasm, small amount of eosinophilic cytoplasm, but muscle differentiation was not obvious. Desmin was positive and myogenin wasn't that much. There were some positive nuclei, and that's what helped to make a diagnosis. In other examples, sometimes the myogenin is really absent. So this is an example of a case that I got last year as a paraspinal tumor. It was a spindle cell. It has a rounded nuclei, but it tended to have a lot of inflammatory background. And to be honest with you, on H&E, many people looked at it, and we felt that it looks more like inflammatory myofibroblastic tumor. It did have desmin positivity, which is described in inflammatory myofibroblastic tumor, but the myogenin was completely negative. We stained multiple sections. We weren't able to find positive nuclei. And what saved the day that we did MyoD1, which highlighted the spindle cells. So this is one area in which two markers are not enough. Desmin and myogenin are not enough alone in the spindle cell sclerosing type of rhabdomyosarcoma, and MyoD1 or myoglobin are required to make a diagnosis or genetic testing. Botryoid variant, as you know, it's usually associated with hollow organs, tend to have the polypoid appearance. Microscopically, it has the characteristic loose myxoid background, and it has the surface condensation known as cambium layer. Also, desmin and myogenin are positive, but less than 70% of the nuclei are positive with myogenin. Anaplastic is a variant that we see sometimes and now is being looked at in the COG studies, and probably is going to be separated as a several different type. Right now, it's treated as under embryonal rhabdomyosarcoma, but it is associated with more aggressive course. And what you note is those anaplastic, large, hyperchromatic nuclei with very bizarre mitotic figures in the larger cells, similar to anaplastic Wilms tumor. By immuno also, both stains are positive, desmin and myogenin. The alveolar rhabdo has two types, the classic, which is the one with the alveolar formation, and the solid variant, which is usually monomorphic type of nuclei mimicking Ewing or neuroblastoma, basically. The nuclei are uniform. They tend to have either coarse chromatin pattern or sometimes apparent nucleoli. So there are two kind of nuclear features, but they're monotonous. And you can see how these tumors like mimic Ewing sarcoma, difficult to make a diagnosis without appropriate stains. In some tumors, you may notice the wreath-like cells prominent. Some tumors do have that. The giant cells are very common, and you have this wreath-like arrangement. Those are clues for alveolar rhabdomyosarcoma. Some variants tend to have the clear cell cytoplasm. We don't know why, but when you stain them, they are myogenin positive. So those are different variants of alveolar rhabdomyosarcoma. Sometimes they tend to have very Indian-like filing, small nuclei with very collagenous background stroma. You may see starry sky appearance, alveolar formation, prominent nucleoli. But the clue is that you need to do Desmin is positive. Myogenin, it stains more than 70% of the nuclei. And when we have something like that in routine practice, when I find that the myogenin is more than 70%, I usually say in my report, rhabdomyosarcoma favor alveolar, and you are required to send that for genetic confirmation based on our children oncology group studies. So the molecular genetics in alveolar rhabdo, this tumor is associated most commonly with a translocation either 213 or 113 that causes abnormalities in the PAX gene. There are other tumors that are fusion negative, but they tend to have different PAX abnormalities that are discovered by not conventional cytogenetic, by either microarray or next generation sequencing. So we do multiple molecular tests in routine practice here to confirm this type of tumor. And as you know, the management for alveolar rhabdomyosarcoma is different than embryonal rhabdo. Desmoplastic small round cell tumor is a rare tumor, but very aggressive. It may have a different histological pattern. Usually the tumor cells are a little bit larger, rounder, angulated. They tend to nest, and they tend to have a lot of stroma or collagenous background. They may show neuroblastic differentiation or even glandular formation or trabeculae, sometimes individual type of cells, but very sclerotic stroma in the background. By immuno, this tumor is polyphenotypic, meaning it may have epithelial, muscle, neuronal marker differentiation. Classically, they are positive for keratin, epithelial membrane antigen, vimentin, desmin, and NSE or PGP 9.5. Classically with desmin, they show the paranuclear type of staining. EMA is usually patchy, and NSE can be patchy or diffuse. They show CD99 positivity, but they have to be myogenin negative, because as you see, this is very similar to alveolar rhabdomyosarcoma histologically. And you are required to do molecular testing to confirm this tumor. Usually the fusion gene partner is WT1 with the EWS. Dr. Taher, I can stop anytime if you want to, or continue for 5 more minutes, because I see that we reached the top of the hour. Can you hear me? I'll continue if you're okay.
You can, yeah.
Okay. So poorly differentiated synovial sarcoma can sometimes mimic around the blue cell tumor. Usually synovial sarcoma is discussed under spindle cell tumors, but the round cell type actually enter the differential diagnosis, especially on small needle biopsies. Those tumors are characterized by small round cells that you don't see any line of differentiation. You may, after exhaustive look, find a little bit of spindling in some areas. By immuno, those tumors have CD99 membranous staining, so very much like Ewing peanut tumors. But a helpful stain in our practice, I find, is TLE. TLE is a not specific stain. It is sensitive, so it's good. It stains many tumors. But with synovial, it usually has to be the majority of nuclei. So I require diffuse nuclear staining to call it synovial sarcoma. Other stains that are positive may be cytokeratin and EMA focal, usually in the round cell type. By doing molecular, you're going to find the translocation X18, different fusion genes with the SSX gene. Usually the SSX2 more common in the round cell type compared to the SSX1 that's more common with the spindle cell or biphasic type. There is a subset of undifferentiated round cell sarcoma that we used to push all undifferentiated tumors when we cannot call it into specific one of the entities that I already described before. We used to say undifferentiated round cell sarcoma, and based on the children oncology group, those all used to be in the past treated as Ewing, which is the aggressive sarcoma protocol for children. Now we are learning more and more with the next generation sequencing, more sophisticated molecular tests that we are identifying newer and more like rarer but specific subtypes. And the two most common ones that I'm going to talk about them, they still morphologically look like Ewing, and that's why they are referred in the WHO as Ewing-like sarcomas. The two most common types that are now more defined, but we're still learning about them, and we maybe find other types of these sarcomas with more sophisticated techniques. The cis-rearranged sarcoma, which is the most common of these undifferentiated sarcomas, it appears to affect soft tissue, and there are cases described in bone, and it mimics histologically Ewing sarcoma. And in past, actually, we used to call them atypical Ewing based on histology and immunostaining alone. Now, this arrangement, the CISDUX4, can be discovered by FISH. There is a specific FISH probe for it, or by sequencing. And it is required to do that nowadays to confirm this diagnosis. So far, this tumor is being treated like Ewing, but I think it's requiring more knowledge to actually be able to help those patients to be treated differently. Those tumors tend to be much more worse than classic Ewing sarcoma. And the histological clues for us to suspect this tumor is that usually the tumor is heterogeneous, like I showed you in the previous picture. Like there are some areas with a little bit of spindling. There are round cells, but they're kind of different types of roundish nuclei. Some of them are kind of irregular. They tend to have a little bit more cytoplasm. So this is what we used to call in the past large cell type Ewing sarcoma or atypical Ewing sarcoma. Sometimes they tend to cluster, have some epithelial hint to them. Stroma sometimes very myxoid or very fibrous, not like classic Ewing, which tend to have no stroma in the classic cases. Usually CD99 is positive and strong and membranous, but there are cases in which the staining is patchy. So if you have a tumor that looks like Ewing, but patchy staining, suspect this tumor. WT1 tend to be positive. There are other newer markers like the ATV4, or there is an antibody for the DUX4 now that is nuclear that can confirm the diagnosis. But still, molecular confirmation is the standard of care for us to confirm this tumor. This is an example of such a case in which the tumor appeared to have in some areas like more myxoid in some areas more cellular. Maybe it was very highly mitotically active. The nuclei were a little bit pleomorphic. They're roundish, they look like Ewing, but more irregular. The CD99 in this case was patchy. I wanted to call it Ewing, but with this like patchy staining, with this ERG stain that wasn't diffuse, I sent it to molecular confirmation and turned out to be Cysduck's tumor. The other subtype that is, it's less common, but is being found more frequently nowadays, is the B-core rearranged sarcoma. Again, this tumor was unusual. It's usually bone primary, but it is described also in soft tissue. It tends to have more like elongated spindle type of nuclei, sometimes ovoid, more pleomorphic looking cells. And again, CD99, usually positive, but can be patchy, and you need molecular testing to confirm it. So in this case, what happened, the CD99 was really diffusely positive, but histologically something didn't look right in this tumor. And the location, this was a mesenteric mass. It was attached to the intestine. So I sent it for the molecular testing, and it turned out to be the B-core associated sarcoma. That's it for me, and I can take questions. Thank you. You are muted, Tahar. I cannot hear you. You're muted.
Professor Yacoubi.
Now you're still muted.
Thank you, and so thank you very much for this very good lecture, very comprehensive, interesting. We have some questions from the audience here on the chat. In the chat box, there's the first question: can we use MIB1 to determine mitotic activity?
No.
No. Yeah, because we count the MKI, because we count the apoptotic and karyorexic can be catched by MIB1. The next question: is it sufficient to have a positive CD99 and NSE to make the diagnosis of Ewing sarcoma?
As I said, if it's a classic, like if you have a bone biopsy and your CD99 definitely membranous, you got the diagnosis in the classic age group. But if you have a soft tissue mass and your CD99 is iffy, like the ones I showed you, then you really require to do molecular testing. Is the question to differentiate neuroblastoma? So if your differential is neuroblastoma undifferentiated versus Ewing sarcoma, in neuroblastoma, the NSE is 100% positive diffusely in the majority of cases, CD99 negative, while Ewing is really CD99 diffusely membranous and NSE is patchy. So if you have that combination in a classic age group, it's okay. I saw a question about treated neuroblastoma and which classification system. You do not do Shimada classification on treated tumor. So that's the first thing. It has to be primary untreated. The reason is that treatment changes the maturation. You cannot do the differentiation and maturation after treatment. So if your clinician asking for Shimada on treated tumor, tell them you cannot do that. What you can say, this is a treated neuroblastoma with necrosis, ganglionic differentiation, etc. That's how the report reads. And we don't know, we have no prognostic implication or difference with how the tumor looks after treatment. is it better to have more differentiation, or is it better to have complete necrosis? We really don't know yet. And that's being looked at now in the International Neuroblastoma Classification. They are looking at this. But right now, you do not do Shimada on treated tumor. So what tissue control can we use for myogenin?
Yeah.
For myogenin, rhabdo. I don't know. I don't think
I think that I think there's no other control tissue.
Yeah, undifferentiated rhabdoid tumor, because that's what they stain.
Maybe in embryon or fetus, we can find some cells, muscle cells, undifferentiated cells.
Yeah, but you have to control it with a rhabdo to say, yeah, it is.
Yeah, exactly. Yeah. The next question is about, I think, Doctora, about
Desmin negative, myogenin positive. So
yeah,
anything can happen. Usually, no. But if your tissue quality is not very good, and if it's alveolar, I would have to say Desmin sometimes is very, like, not as diffuse as myogenin in alveolar. I've seen a case like this, but it was a treated rhabdomyosarcoma. So after treatment, for some odd reason, the Desmin may decrease or disappear. But in primary tumors, I haven't seen it yet, unless the sample is small or poor quality.
Next question: solid variant of alveolar rhabdomyosarcoma is it a morphological diagnosis?
Actually, it's a molecular diagnosis. Because what we can say in our report, as I mentioned, that this is a rhabdomyosarcoma, we favor alveolar. I would never say, except if it's like the classic, like nesting. The problem that we don't get enough tissue nowadays to see the classic appearance. And for some odd reason, all our needle biopsies show usually mostly in pediatric the solid variant. The classic alveolar variant is more common in older patients, not in the pediatric age group, and not with limited sample. So the classic, what we usually say is rhabdomyosarcoma, favor alveolar pending molecular. That's the classic routine practice that we have.
Yeah. Doctor, I have a question about mic-in amplification.
Yes.
Still you do it by fish, molecular fish, or we can there's no protein result of this amplification, and we can do it by immuno? No.
We do it usually by fish or microarray. But there are places where they do immunostains, but I don't think this is the standard.
There's no good correlation. There's no good correlation between,
Exactly.
Yeah.
It's not the standard of care. So what I'm saying is like how we do it in real practice. Now, if you're stuck, you don't have the molecular test, because most labs do it on fresh tissue.
Yeah.
If you don't have a lab that's sophisticated, able to do it off paraffin, if you do immuno, that's the least you can do. You know what I mean? I don't know. There are labs that they do it, and if they're comfortable with it, that's good. We don't do it. We do it off fresh tissue.
I think fish on paraffin embedded tissue is possible now, because we do it for a lot of for breast, for HER2, for many things.
Not all labs are equipped to do it. Or the other problem is in the United States, you know that all these children are assigned into children oncology group, and the protocol is written for fresh tissue. It's not written based on the paraffin.
Yeah.
So you need like permission to allow a patient to register if you don't have fresh tissue.
Okay. Maybe the last question about this cessation of liquid biopsy. For this patient for neuroblastoma, is it possible, and you are doing, as I know, is it not in practice, in routine practice, but is there any studies about MYC in liquid biopsy?
I am not familiar with that. They just put my name on a new IRB that we're going to look at this in our population, but I will believe it when I see it. So far, I'm not so sure. I mean, there are promising results to say I can detect tumor without having invasive procedure, but to actually do NMIC and sophisticated like histology and bypass histology, I don't think it is standard.
No, about histology, I think that sometimes they are sometimes there's complementarity between two techniques, and tissue biopsy is compulsory. I think it is in need till now. But there's a lot of thousands of papers published about liquid biopsy now in different organs.
Yes.
And especially, I think in France, they started as routine for EGFR in lung cancers. Mm-hmm. So I think also they start to study it in pediatric tumors.
Yeah, at the University of Michigan, it's being done. And my name is in a protocol that we're going to look at it. I don't have the results yet.
Yeah. Okay. So thank you. There's no other question, I think. So the session is finished. Thank you very much, Doctora, for your support for our community of pathologists in Middle East and in North Africa.
Anytime.
إن شاء الله. شكرا يا دكتورة وسمحنا على أخذنا من وقتك.
Stay safe, guys. البسوا الكمامات.
Thank you very much.
Bye.
Thank you for all people, and happy weekend for all people. Thank you, everybody. Thank you.